Okay, welcome everyone. Good morning. I'd like to welcome Dr. Edka Kambani this morning, who's bringing rounds on Introduction to Quality Improvement Research. Just to tell you a bit about Edka, prior to med school at the University of Toronto, she completed a BSc in Psychology of McMaster, a Master's in Science at the University of Toronto, and then after doing her anesthesia training at the University of Toronto as well, she went on to get further training in patient safety and quality management, earning her certificate from the University of Calgary, so she's been around. She currently works at the Niagara Health in St. Catharines and has joined our faculty as assistant clinical professor recently, and she'll be giving academic half-day seminars to our residents on transition to practice and applying QI and patient safety to everyday perioperative life. I'd like to welcome Edka and thank you for presenting it as she's almost due to deliver for the first time. So if anyone's on OB, it'd be a good time.
Thank you so much. I just wanted to also point out this code that I hear is really important. This is on the first slide there. So I figure this is a good place in case I needed an epidural. So today my talk is going to be an introduction to quality improvement research. For now, I'll stand. Occasionally, I may sit down, and you'll just hear this random voice because I think I'm so short you won't be able to see my head. So if you hear a random voice, it's still me talking. And I thought I'd start off with a cartoon. Great, just what we need, another quality improvement campaign. And I think regardless of which hospital you're at, I'm at Niagara Health, I was at Western with Matt McFarland a few years ago. No matter which hospital you're at, everybody is talking about QI. And I think it's a great opportunity for anesthesiologists to get involved because we always kind of think about worst case scenarios anyways. It kind of works in our line of thinking. And I think that there are great opportunities for us to do research, some that we've already done, and can continue to do research in this area. But a lot of times people aren't familiar about how to go about doing a quality improvement research project, and that's what I'm going to chat with you today about. So the objectives today is to talk about what a quality research project is and what it's not, discuss some of the ethics requirements in REB for QI research, it's a little bit different, and then provide some examples of QI research. But before I do that, I just wanted to go through a brief history in quality. And quality improvement has been getting a lot of attention in the last 10 years. One article in particular that made headlines in newspapers was actually the study done by the BMJ that showed that medical errors was the third leading cause of death, just third to heart disease and cancer. So COPD, diabetes, Alzheimer's, all well below what medical errors are. But when we look through and look at Canadian data, it's actually been our Canadian data for quite a while. So in 1999 came the report To Err Is Human, where we realized that medical errors were more common than AIDS, breast cancer, and car accidents combined, morbidity and mortality from that. So that's quite telling, and the rate was about 7.5%, probably gone higher as we're reporting more. And then there was this report that came out called Crossing the Quality Chasm, where they talked about these are 6 domains we should look at if we're trying to have what they call a high reliability organization. So you really need to look at these 6 domains when you're looking at quality in healthcare, making sure it's safe, equitable, effective, efficient, timely, and of course, patient-centered. And what the Crossing the Quality Chasm showed was that we have 3 main issues. One, we underuse resources. So we don't comply with 100% with the guidelines. In fact, there's been studies that even when you look at ACLS guidelines, the amount of time it takes to go through something as ACLS to get it adopted and implemented into a hospital, it takes about 368 days, so just over a year, to adopt to the current guidelines of ACLS. So there's underuse of beneficial services. We have overuse of services, and that's where all the Choosing Wisely campaigns come in, that we're ordering tests that we don't need, that are draining the healthcare resources. And the third area that we are finding is that we are making errors that are leading to patient injuries. And that's the whole idea of the Swiss cheese model, that we don't have enough force functions, double checks in our system, and as a result, when there's one problem in one area, it can slide all the way down because we don't have these barriers of defenses. So I remember right right around the time I was about to start medical school, I saw this article about a dialysis mix-up kills 2 people. And this happened in Calgary, and this was a big topic when I went to do my QI on patient safety. And so 2 critically ill Calgary patients died after they were given the wrong drug during dialysis. The patients, an elderly woman and a middle-aged man, were given a potassium chloride solution instead of a sodium chloride solution in an intensive care unit. And you think, how can that happen? You know, in this day and age, how can you confuse sodium chloride, oh, I hope my slides still came back. Okay. Sodium chloride with potassium chloride in this day and age. And that was when I was a naive first-year medical student. And then I started actually working in a healthcare system, and I said, oh, I know exactly how that can happen. And when you look at the bottles, these are the bottles. They look exactly the same. The medication was mixed up at night under poor working conditions. It was dark at night with a brand new pharmacy tech. And the reason this case got attention versus other cases, there may have been a lot of other cases, is it just so happened that the daughter of the elderly woman who died was a medical legal lawyer. And so it made attention to the media and the press, but this probably could have happened in a number of patients, and it could have been unnoticed or dealt with the hospital kind of privately. But that's what kind of garnered attention in Alberta, and that's what really kicked off Alberta's quality improvement plan in their organizations. But it also really highlighted the need for us to do research in this area, and specifically looking at how can we make our work environment safer. So when we're talking about QI research, we're looking to answer 2 questions. 1, how are things done now? And 2, how do we make it better? So the fundamental part is that we're trying to introduce change. A lot of people say, okay, let's just do a QI research project. Let's just do a quick audit, and that's a QI requirement. You know, Dr. Paul wants us to do something QI. Okay, let's do an audit. But it's not an audit, because what we're trying to do is we're always trying to make things better, and we're trying to implement change, and that can be done through a variety of ways, which I'll get into. So you're always trying to involve systemic activities. So when I was talking about that Swiss cheese model, the reason why it's so hazardous and not have enough double checks and defenses is that it relies on perfect human performance, which of course makes 0 sense because humans are inherently imperfect. And so we're always trying to come up with programs where there's systemic analysis of things. So we're kind of getting away from the shame and blame and trying to see how can we make our system safer. So we're looking to monitor, assess, and improve, and that QI is always ongoing. We're always trying to do cyclical efforts to improve what we're doing, and even if we're able to have 100% compliance with something in one area, maybe 5 years later, let's say it's antibiotic prophylaxis before surgery, 5 years later our numbers go down and we have to go through the whole process again. So it's always a continuous process. So just like any other research project, we start off with our hypothesis. And what they talk about in QI is this whole idea of SMART objectives. So you should have an objective that's specific, measurable, achievable, relevant, and time dependent. So something about we want to reduce the time it gets for patients to get their antibiotics before surgery within 30 minutes, and we want to have this done within a 1-year time frame. And this is relevant because this is something that NSQIP is looking for, and we want to do this within an 8-month time frame. So we're really looking for specific measurements. So there's been a lot of work published in anesthesia that is on quality improvement, but not all of them are exactly follow this structure, and you can see that how it can lead to issues. So this is an article on modification of anesthesia practices, reduces catheter-associated bloodstream infection, a quality improvement initiative. And this is their hypothesis. So what's wrong with this hypothesis? Anyone tell me? Yeah. Yeah. Like what do we do that is like, yeah, what else is wrong with it? I mean, it's a published article. It's got to be good. So the other thing that stood out to me is what was your rate and by how much and by when are you going to reduce things. So there's missing those SMART objectives that we talk about. And those are really important when it comes to QI because it helps formulate what your data is going to be. And I think sometimes there's a lot of, I guess, belief that QI isn't really data driven and that it's kind of a soft science compared to traditional randomized control trials. And while the methodology is a bit different, it is actually very much data driven. And why it's so important to have data is because it separates what's thought to be happening to what's actually happening. So maybe you think your posterior puncture headache at your institution is 2%. And the nurses have been complaining recently, and they're like, oh, another posterior puncture headache. And they're like, oh, it's just 2%, it's fine, it's been 2% for years. And then you actually go and look at it. And maybe it's as high as 15%. So that's why it's so important to start to look at what's actually happening and versus what your belief is or what your belief was 5 or 10 years ago. And it establishes a baseline. And then when you start to monitor and start to maybe implement interventions and changes, you can actually go back and say, hey, 3 months ago, our posterior puncture headache rate was 15%. Now we've done better education. We've done this. We've changed this around, and we've changed our catheters around, our equipment. And now it's actually gone down to 10%, and you can compare things. And you can even compare across sites. So that's why one of the reasons why data is important. So just to give some other examples of the different types of data you can collect and different types of measurements you can collect. So let's say you want to start a chronic pain clinic because you're seeing that there's more and more patients that are being readmitted for pain. We have this opioid crisis going on, and you want to go to the hospital and say, I want to start this. Give me some money. I need money to have this. And the hospital will say, okay, well, we don't have any money. Thanks. But if you want to actually make your case, you need to be able to show that this is a problem, and you need to be able to show and measure how there's a need for your clinic. And you come up with your SMART hypothesis about how you want to reduce readmissions rates by 1 year by instituting this chronic pain clinic, but what are you going to measure? So there's 3 types of measurements that we talk about in QI. So you have your outcome measures, so that's like your 30-day readmission rate. But you also have things such as processing and balancing measures. I'm not sure if you've seen this in the literature, but a lot of times when you're reading QI articles, they'll say our outcome measure was this, we had balancing measures, we had process measures, so I thought I'd quickly touch on it. So your outcome measurements are your 30-day all-cause readmission rate or the amount of people who are consuming opioids, and the process measures are what percentage of your patients are being booked in follow-up for their pain management, what percentage of your patients are getting a standardized education on disposal of narcotics, and then you have things such as your length of stay, which is your balancing measures, and making sure that the new work that you're adding on by having an extra clinic is not actually going to fall apart because people hate you for doing this and you're adding more work to them. So there's 3 different kinds of QI methodology that's the most popular that's used. And the most common one that's used is the QI methodology of PDSA cycles, plan, do, study, act. And what that basically talks about is in the planning stage, what you're trying to do is come up with your SMART hypothesis, come up with what you're going to measure, your outcome measurements, your process measurements, your balancing measures, and then figure out what's going to be your intervention. You establish your baseline. So the planning stage out of all of these stages of the PDSA is actually the most important one because that's where you're getting all your your background and your methodology, so to speak. And then the doing part is when, after you've established your baseline and you want to introduce an intervention, that's when you say, okay, well, based on our baseline, we are going to start this project and we're going to start this change. And that's where you carry out your change and then go back and study and remeasure and say, was my intervention actually effective? And then if it is effective, you can roll it out and start on another PDSA cycle. Typically, you need about 2 or 3 PDSA cycles because sometimes you think your change idea is going to be revolutionary and then it falls apart on you. And then if it's not effective, then why are we even going to introduce this change? So that's why sometimes you don't actually need these huge sample sizes for QI research because you're not even sure if your intervention is going to be effective. So you start off with kind of a small sample size, which is just enough, introduce your intervention, see if it's working. If it's not working, no point rolling this out to 200 patients. There's also the Six Sigma, I always pronounce that wrong, Six Sigma methodology, and that kind of comes from the automotive and manufacturing businesses. And what that is this is more for when you're trying to look at things like improving the medication errors or improving human factors where medications look alike. So you don't want to have any medications that look alike in your pharmacy. So it's kind of the same idea, but what's a little bit different is you define the problem, which is the same as PDSA. You measure the problem, analyze, and improve. The main difference is when you're going to controlling the situation, you're looking at sustainability. So you look back time and time again, how many times do you have medications that look alike? Are they always going to be in different locations? And this is where you're trying to get that zero error and high reliability. If you're trying to look at an organizational standpoint, this is what organizations look like. They have like, it's almost like karate for Six Sigma. They have green belts, they have black belts, and that's what organizations are looking for. As like somebody said, oh, I have a black belt. And it's like, that's great. And then I realized it's because they have this organizational black belt in Six Sigma, and this is what they specialize in. And then there's the FADE model. And sometimes this is the easiest model for people to understand because it just seems to make sense. It's not as maybe as hokey as a PDSA cycle sounds, where you're, again, trying to focus, define the problem, collect the data, develop action plans, implement them, and measure and monitor to see if that you're actually having success. So some tips for testing change is keeping the changes small. You don't need to have huge, gigantic changes. I think sometimes for when I was implementing ERAS at McMaster, we said, okay, well, one of the changes we're going to do is we're just going to give Tylenol to everybody. That's it. That's all we're going to do. Unless they have major liver problems, let's see what just adding Tylenol does. And it actually decreased their pain scores significantly. And sometimes it's all you need to do. And then you involve care teams that have a strong interest in your goal. So let's say, for example, using that ERAS example. So I really wanted to implement ERAS at Western. I went to the chief of surgery there, and he was stressed out because there's this thing called quality-based procedures, QBP funding, and he's like, oh man, I have to do QBP funding, I have to follow ERAS, but I don't know how to go about it. I said, okay, why don't we work together? You know the right people, I know some of the methodology, let's get our heads together, let's see who we can involve, and let's see how we can implement it. And then you study the results after each change, and of course looking through that the overall performance is improving. Like for example, for ERAS, our length of stay was going down, our readmission rates were going down or staying the same, and patients' pain management was going down was improving significantly. Their pain scores were going down as we instituted multimodals. So this is a question I often get asked, and I just wanted to touch on this. Sorry, it's a busy slide. So people always ask me, oh, well, if it's QI, I guess we don't need to do REB. We don't need to go through it. And it's interesting because I've worked in a couple different institutions, and it seems to be very institution specific. So when I was doing research in Calgary, they have what they call their RECI form, which basically is like a form you filled out, and it kind of gave you, put in a bunch of answers to things, and is this going to be, are you introducing a new medication? You say no, and then it spits out an answer, oh no, you don't need to go through REB, yes you do need to go through REB, or maybe. And then other institutions also ask for you to, even if you're doing QI research, to go through full REB, and some do an expedited review. So there hasn't really been like a blanketed statement about this is how we're going to do it. There is the Tri-Council policy statement saying that while research must undergo ethical review, program evaluation QI does not follow under the traditional REB boards. However, and this is like their exact statement if you want to look it up. However, most institutions will want you to at least pass it by their REB. And what REBs are looking for, and I can tell you this because I used to sit in an REB, they would start to look at, would participate specifically for QI. They're trying to look at, would the primary purpose be for monitoring, oversight, and improvement of the organization? Most likely QI projects would. So even if you didn't want to publish, even if your goal wasn't to publish, would you still be doing this to meet the internal needs? Oftentimes, yes. A lot of times QI is routinely collected data. You're not trying to get new information. You're not introducing a new drug, a new study. You're just getting what you normally do, monitoring what you normally do on an everyday basis. And is it applying or is testing a framework rather than testing a new theory? And most of the times, if you answer yes to these questions, then it's considered QI, and you go through either an expedited review or or you can get an exemption from REB depending on the institution. So when in doubt, reach out to HIREB. We're doing one currently at Niagara Health, which I'll get into when I talk about examples of QI research. And there I went through HIREB. I talked to, I said this is a quality improvement project. I sent them a couple emails. I sent them a project proposal. They're like, oh yeah, this is definitely QI. Here you go. I think I submitted my REB on December 21st, and by December 24th, so Christmas Eve, I got approval. So it was great because I didn't have to go through this full review, and they saw that my intentions were basically to monitor things that we were doing on a regular basis. So the last time I checked, so it has been a couple years since I submitted something for CAS, but they did say ask for a statement of REB or a statement of REB exemption. So even in your methods, you should still say we went through an expedited review or we were exempted for REB. Canadian Journal of Anesthesia still asks for that. So always hold on to the records, and always, if you're in doubt, go to your REB and they'll help you sort it out. And especially because QI research is becoming more common, they're a lot more familiar. I think a few years ago when I first started doing this, they're like, oh, we should send you for a full review for implementing ERAS. And then now they're just like, oh yeah, this is definitely QI. We know what QI is. Here you go. Here's your stamp of approval. So this is just an example of QI research. So this is one that we did. So one of the things I did after I left Western and I was in the GTA is I was doing anesthesia, but I was also consulting for different hospitals on QI. And even though pressure injuries wasn't an area of expertise, this was something that they said, hey, you have this area in QI. Let's see if you can help us with pressure injuries because we need to make this goal because our hospital needs to meet these requirements and come up with a standard because funding is attached to it. And so I kind of helped them out with this project. And the reason I'm showing you this is because I just want to show you, this is a super busy slide, but I just want to show you the measurement section. So the measurement section, because I think when we think about research papers, we think about methodology. And when I'm talking about these PDSA cycles, you're like, how do I even write up a PDSA cycles? But in QI journals, it's actually very appropriate to talk about your measurement. This is your baseline. You started a strategy of PDSA cycles. And sometimes people think, if I'm doing these PDSA cycles, how am I going to write that up for a journal? And journals do accept this. This is published work, and more journals are seeing how PDSA cycles are part of a regular methodology section, just like randomized controlled trials, even though most of the studies that we do in QI are observational, non-randomized. And then just some exciting research that we're doing in Niagara Health, also through with McMaster as well, is we're starting to look at the opioid crisis. So when I talked about those 6 domains in quality, what we talked about was things that were timely, effective, patient-centered, and I think you'd be remiss if you didn't open up a newspaper and actually see that the opioid crisis that we're facing is affecting everybody in Canada. As the sales are going up, the deaths are going up, the amount of admissions are going up exponentially. And 16 people are the average number of opioid poisonings resulting in hospitalizations each day in Canada. And the deaths, I mean, this is old research, but 1991 to 2004, deaths have doubled. And I think from now, if you were to look at this is Canadian data, but if you look at just the Ontario data, it's actually tripled. So it's more so than actually all the accidents on the QEW. I think it was like 437, and the deaths due to opioid-related crisis was 784. So almost double for opioid crisis causing morbidity and mortality. So then I started to look at and think, okay, well, this is a big topical area in the newspapers, but how does it relate to us? Are we part of the problem? And it turns out Canada ranks second only to the US per capita for the consumption of prescription opioids. And this is a table that's talking about who are the prescribers. And we see family doctors, of course, dentists, but surgeons as well. And that's obviously affects what we do, because we do what we can to manage our pain intraoperatively, and then postoperatively, surgeons give out their prescriptions. And what we're seeing more and more, that even though we're having an opioid crisis and there's more and more people being admitted in hospitals, the actual amount of people who are prescribing opioids is only going up. So it's kind of strange that you have this opioid crisis and we're prescribing more narcotics. So that's why I feel like we need to start looking up. So 44,000 prescription physicians prescribed opioids in the last year, resulting in 9.2 million prescriptions being filled in 2015 and 2016. And that's up from 8.7 million from 2013 to 2014. And that means 14% of the population is actually receiving an opioid. So we definitely have a problem, but we also have a problem of how we manage it. And the overprescribing of narcotics by physicians could be considered a real driver for the opioid epidemic that we're seeing. So again, we come back. So I thought, okay, if I want to tackle this problem and I want to see what the opioid consumption is at our hospital, and are we overprescribing, how am I going to do this? And of course, I go back to my roots of QI methodology. What am I going to measure? What's my hypothesis, first of all? Is it going to be SMART? What am I going to measure? What data am I going to gather? What interventions am I going to take place? And then how are you going to act on this? And how can this be translated towards not just our hospital, but perhaps at St. Joe's, perhaps across the hospitals in the GTA as well? So for our study, has anybody heard of the HQO Cut the Opioid campaign? Anyone heard of that? So Health Quality Ontario is an organization where they're looking at reducing opioids. And so one of the things that they've asked hospitals in Ontario to do is to reduce the amount of opioids that they have by 30% by April 2020. But in order to do that, so they come up with their own SMART objectives. But in order to do that, we have to understand how much do we prescribe. And that's when we go back to our measurements, I needed to figure out what was going to be our primary outcome, what were going to be our balancing measures, what were our process measures. So how much do we prescribe in our we were looking at elective day surgery patients. We didn't want to make it complicated. We didn't want to do hips and knees because those patients are often done under spinal, then they stay in the hospital, and sometimes they get IV narcotics, sometimes they get PCAs. So if we just wanted to see how many patients were going home with narcotics, let's see, okay, first of all, for elective day surgery patients, what do they prescribe? And then some of our process measures are, do our patients use all that we prescribe? So how we're going to look at that is we're actually going to, we photocopy the prescriptions that the surgeons are giving out for 19 surgeries, and the reason we picked 19 surgeries was because when we look at the American literature, we saw that there were 19 surgeries where overprescription was done for a lot of elective outpatient procedures. And we said, okay, well, how is this done in our Canadian population? And another thing is since we're learning that a lot of people, it's a common story we see in the news, 14-year-old found dad's old knees, narcotics that he got from when he got his knee scope done 3 years ago and overdosed on those and died. So do patients actually know how to discard unused opioids? A lot of people think you put it in the trash. That's actually incorrect. In the US, they say you can put it with some soil and dirt and throw it out in the garbage. Yeah, but that's not correct, and you can't flush it down the toilet. That's not correct either. You actually have to take it back to a pharmacy. And there's websites in Canada that show you where you take it out to, but do you think we write that on prescriptions? I haven't seen it on a prescription, right? Do you think it's easy to write on prescription? You probably have to go through like a lot of red tape, but it's literally a stamp on your prescription. And hospitals are looking at this. So I presented this presentation about this opioid study we're doing at the MAC, and they said, hey, if we wanted to get something pre-printed onto our opioid prescriptions that said, this is how you dispose of your narcotics, how hard would that be? And as long as the spelling's okay, and as long as it follows the Niagara Health letterhead, we're fine. So I'm already thinking about my interventions, but I'm still in the planning process. And then you always think about your target audience. So for us, for Niagara Health, we have the St. Catherine site, we have the Welland site, and we have the Niagara, Greater General Niagara site as well. So we can actually compare across all three sites, which is where it comes back to what I was talking about, looking at procedural changes, and also if we get baseline measurements, we can compare against all sites. And then we're looking at elective day surgery patients, like I said, and we looked at ones that have been shown in the literature to be due to overprescribing, and we wanted to see how do we compare. And a lot of times, and the reason we're doing this kind of study in Canada is because, first of all, we don't have Canadian data on this. And second of all, a lot of times when you read the American literature in the discussion part where it shows that actually, oh, your patients are not using all the narcotics that you prescribe, a lot of the physicians are saying, well, I never prescribe the narcotics anyways. It's always my residence. I would never prescribe this many narcotics, right? And there's a whole idea of transferring accountability that we want to get away from. And then what we actually see is that when we're doing in a community setting, we prescribe our own narcotics. So you don't really have that same excuse because you're the one as the attending doctor who's writing the prescription. And the reason we're looking at 19 surgeries is because we wanted to look at all surgical services. So we didn't want to say, oh, vascular, you guys are amazing. You don't have any problems. No, vascular still has varicose veins. That's where patients have been shown in the literature to get way more narcotics. Do you actually need narcotics for varicose vein stripping? Actually, oftentimes, no. And that's what the data shows us. So when we go back and we present, and one of the things that we want to do is an audit and feedback to our surgeons, we want to say, hey, did you know that you prescribe, let's say, 30 Tylenol 3s for your varicose vein stripping, but we actually called your patients day 10 to day 14 post-operatively, and they only actually used 3 of them. And those are powerful messages, right? Because then you're saying, okay, we looked at, 1,000 patients, 500 patients, which isn't hard to get considering all the amount of elective day surgery cases we get, and said we called all of them, and what our preliminary data show, I don't have it here with me because it's still getting worked out and our sample size is still small, is actually for all the surgeries we're looking at, patients are only using less than half of what we prescribe. So some cases, like in appendectomies and cholecystectomies, patients are only using 17% of what we prescribe. For shoulder cases, it's sometimes up to 50%, depends on how well your block is working. But they're actually not using a lot of the narcotics we're prescribing. But the other thing that we're doing is we're trying to avoid the Hawthorne effect. So we're purposely, and I hope this kind of stays a little bit on the down low, even though I'm presenting at a citywide grand rounds, but we're not telling the surgeons exactly what we're doing. You know that there's some sort of QI study, and it's like, oh yeah, there's Aetha, she's doing her QI study, we'll just let her do her thing. But we're not telling them what we're doing. And the reason we're not is because if I tell you, hey, we have this problem with the opioid crisis, and I'm going to be monitoring exactly how many narcotics you prescribe, people are going to automatically reduce their numbers, right? It's going to introduce that bias. So we're just going to say, just do what you're normally doing. We're doing some QI stuff. Don't worry about it. We'll keep you updated on our results. And we want to be clear and transparent, but we also want to establish an accurate baseline. So that's what we're kind of keeping it a little bit on the down low. And then, of course, we're planning our interventions, such as an audit and feedback. So an audit and feedback is basically when you get the stakeholders involved. In this case, with our study, we're looking with the surgeons and saying, and of course, when I was talking about this, it's always a little bit hard for anesthetists to go to surgeons and say, hey, do you know you're doing this in not the best way? So of course, I found my allies, and I got together with the chief of surgery and said, hey, do you want to work on this together? So it's always about finding your allies. And then we need patients, we need the nurses to photocopy prescriptions and help make the phone call. So then that's when I involved the director of patient services and day stage. And then we said, okay, we'll do an audit and feedback depending on our results. So let's say our patients are using all the opioids that are prescribed. That's also good information. Maybe our needs are a little bit different from the US. So we want to figure out what our baseline is and then tell their surgeons, this is the data that we have. So we're not going to be hiding in the background forever. We definitely want to be clear and transparent, but the whole idea of quality improvement is we're not targeting specific surgeons. We're saying this is a problem for our hospital in general, and these are ways we can potentially fix it. And then increasing, of course, the use of multimodals. So it may just seem like simple things, but Oakville Trafalgar, for example, they were able to reduce their amount of narcotics that were being consumed by patients by 30%. How? They put Tylenol on the prescription. They put Tylenol and Advil on their prescription. And automatically, they got a huge reduction. And sometimes it's all it takes. Changing order sets and discharge instructions like I talked about, disposal of opioids. And then, of course, I can think, hey, this worked in the US, it worked for Oakville Trafalgar, a colleague of mine did this in North York General, you know, it's gonna work for us, but maybe it won't. Maybe our population is a little bit different, and maybe, you know, our needs are a bit different in Niagara Health. So we have to remeasure it and see if our interventions are making a difference. And then once we can establish and say, hey, we looked at a big sample size, this is the data we found, these are the interventions we found, I found it to be effective, well then maybe we can start to look at inpatients, patients who are getting PCAs, patients who are getting spinals, and saying, okay, well, how can we reduce that, or how can we help reduce what they go home with, and then plan for hospital-wide implementation. So you always want to start in one area and an area that you're comfortable with, and then go from there. So that gives you a little bit of an example of some QI research that's currently ongoing. And like anything, it's always going to be kind of this winding, narrow path. You're always going to come up with blocks. So I remember when I was taking the Aspire course with Brian Wong, he always said, you're going to have to hear no 11 times before you hear a yes. So a lot of times you want to change the system and all you get is a lot of red tape and you get frustrated, but you just kind of think that that's part of the process. And when people see that you're genuinely interested in improving patient care and you're looking for these 6 domains, and now that you know some of the language, you can use those buzzwords with them, then they do come on board. The admin comes on board. I've got a lot of support from the chief nursing executive, from the chief of staff, from the MAC committee at my hospital. And part of it was the ideas that we had, and part of it was using the right buzzwords. And that's about it. It's how I kind of feel right now. Any questions? Yeah.
Thank you very much. That's very, very good presentation. And talking about benchmark, quality improvement, it has to be cyclical.
Yes.
The second thing is benchmark. What do you use in the benchmark when you look at quality? And secondly, how do you really differentiate that from audit for the regularity of it?
Sure. So, so benchmark, that's a great question. So we're always looking, so when you're looking at what's going to guide what's your gold standard basically, right? Mm-hmm. So then that's where you're looking at what does the CAS put out as the standards for practice of anesthesia? What do major institutional policies say? So for example, one of the things that we're working on right now is the new CS guidelines say for moderate to deep sedation, all patients need capnography, right? And their colonoscopy units do not have capnography. And they're like, oh, it's only if you're using propofol, it's only if you're using this, it's only, no. The CES guidelines are very clear. If you have a Ramsey sedation score of this and this, then you need to be using capnography. And it is a cost to the hospital. So what you do is, so in those cases, you say, this is what the standard is, this is where we're currently at, that let's say only 50% of our patients are using capnography, and we want to get it to 100% in compliance with the CS guidelines. And these are the changes we're going to do. So let's say you start off by doing, and the interesting thing about CS guidelines is we're thinking, oh, maybe we can use like a poor man's capnography, like stick in a capnography into some nasal prongs and kind of get that. But they also say that it has to be used according to Health Canada guidelines. So you can't just use your poor man's capnography anymore. So then you say, okay, well, you know, the first idea is getting an education session out there to tell people these are the guidelines, this is what we have to do. Second one is trialing to see what the additional costs are going to be. Third is going to say, I'm just thinking off the top of my head, okay, well now we're using the capnography, is it improving outcomes, things like that. And then you look back and then you remeasure and say, okay, yes, now we've implemented all these changes, we've told everybody these are our new guidelines, we've said why this is important, we got the finance team on board with it, because the closed cases that you can get from not having capnography is much higher than the cost of the capnography itself. And then now what's the rate now? And if it's like, let's say it's gone from 50% to 80%, well, what do we need to do to get that extra 20%? Does that answer your question?
How often does it have to be quality?
So, I mean, it's always like, so how a lot of people think about it, it's like, you know, maybe we have this capnography, for example, to use that same example, we got everybody to, let's say, 90%, which is pretty good. You know, there's always going to be a few people who are just like, I don't need this anymore. And so 90% we think is acceptable. And then, you know, after a while, what we see is, you know, people are finding it through observation or anecdotally that nobody's using capnography anymore. Oh, the nurses are pressuring us, it's too expensive, whatever else. And then that's when you kind of trigger and say, hey, maybe we should start to remeasure. Does that make sense?
How hard of an intervention is reasonable for a QI study? So I'm thinking about a couple of issues. So we have a bariatric program at St. Joe's, and there's a couple of interventions that are sometimes followed and sometimes not followed. And one of them is the use of a lidocaine infusion intraoperatively. And I think that's a fairly easy intervention. We get our programmers to have that to our EMR as an automatic pop-up, that people will be reminded to start that or give a reason why they're not. And then there's a more difficult intervention where the patients will have pain after the surgery, and most of these patients come with anxiety, and that's what's led to their issues to begin with. And explaining to them that taking opioids postoperatively will not decrease the pain scores, but getting up and moving will help with the gas pain they have, and then the pain will go down because that's typically what happens. I think that's a good intervention, something that should happen before each of these surgeries, but it's a much more difficult intervention to have occur. So where do you draw the line in what you think is a reasonable intervention that you can ask people to achieve?
Yeah, well, I think that that's where, you know, doing multiple different interventions is always helpful. I think that's a great question. So first of all, with your first suggestion about the lidocaine infusion, right? That's a forced function. It's a passive thing. People don't have to actively get involved. It just kind of pops out in front of them, right? And those are the best types of interventions because there's no thinking that needs to be involved. You just check it off. So I think that once people see that, okay, well, we institute this really small thing, and see, look, this is the impact it had. Imagine if we instituted this thing, which is educating patients. And I'm assuming that most of these bariatric patients also go through a pre-admission clinic. So it could be as simple as, hey, now we're going to add a handout on pain management strategies. And if they have questions about it, we can talk about it. Or we're going to just put on our hospital website, make it mandatory for patients to go onto the website and look at a video about pain management. And it is a little bit more cumbersome to do, like it's more upfront work for you to do, but once you get something that is meaningful for the patient, so for example, when we were doing ERAS, we had a similar situation, right? Because patients have these big surgeries and they're used to sitting in bed, and the ERAS data says, no, you need to get up and you need to start moving. And so what we did is when we went to the pre-admission clinic, we talked about, and I talked to our chair about saying like, hey, can we also put in a blurb about this part of pain management? And when we gave booklets out, we talked about how important it was to move and why it's important. And oftentimes when I'd see patients right before surgery and I didn't see them in the pre-admissions clinic, I would also remind them, I'd say, hey, so for, you know, right after your surgery, we're going to get you to move. And they're like, oh yeah, we read that booklet, you know, and then we also got them to be a little bit more empowered because we put things on their patient booklet saying, day one, I moved myself. And day one, physiotherapy came to visit me, and like a little checkbox, so they could be active participants in that. And I think that actually really helped them because I remember seeing a patient post-operatively, and I said, how's your pain doing? They said, oh, my pain's good, but I haven't gotten these check boxes yet. I'm supposed to get up, physio hasn't seen me yet, and they're really much more engaged, we found, with patients.
We're rounds of long-term global for hearts, and they said that the most common reason why surgeons prescribe more antibiotics is convenience, because they don't want to go back, so patients complain and stuff like that.
Yeah.
Has there been any intervention that can address this?
Well, so what we're showing our surgeon, I mean, we're planning to show our surgeons, we haven't showed them yet, but when I was trying to get our chief of surgery involved, he said, you know what, this is going to be, at first he was like, I know this is a problem, but it's going to be a lot of work, and, it's going to be hard to convince them, because it is easier, right? And we're creatures of habits, right? Imagine telling somebody who's done this job for 30 years, and then given the same prescription for 30 years, actually you're just going to give Tylenol and Advil, and your patients are going to be fine. But what the literature shows, and this is what it was really important to have data, is when I went on to Niagara Public Health and I looked at the amount of emergency department visits for opioids, and the graph was like this, like it was so exponential, right? So you can't, that's where data comes in, you can't argue that data, right? If it just keeps going up and up and up, you need to address this problem. And I think that's where data is so powerful and can really help shift mindsets.
Okay, I think we'll wrap it up there. People are starting to head out to.
Yeah.
Thanks very much, Edka.
Thank you very much.